Right, good evening, ladies and gentlemen. I think we'll make a start, though there may be some more people to join us in a few minutes. My name's James Ross and I chair the Board of Trustees, and it's my great privilege tonight to, first of all, welcome you to Liverpool School of Tropical Medicine and to the Leverhulme Lecture. These are a series of lectures started in 1997 with the support of the late Lord Leverhulme and the Leverhulme Charitable Trust. And the series was established in order to attract lecturers of international distinction in their particular fields. And so tonight we're absolutely delighted to welcome Professor Jimmy Volmink, who is Dean of the Faculty of Medicine and Health Sciences at Stellenbosch University and the founding director of the South African Cochrane Centre, hosted at the Medical Research Council of South Africa. Now, I'll just spend a few minutes, for those of you who don't know him, running over Jimmy Volmink's career, a very distinguished one. He was previously Deputy Dean of Research at Stellenbosch University, Glaxo Wellcome Chair of Primary Healthcare at the University of Cape Town, Director of Research and Analysis of the Global Health Council in Washington, D.C. He may talk a little bit about that, I hope, too. After obtaining degrees from the University of Cape Town and from the South African College of Medicine, he worked in hospitals in rural Swaziland and in Cape Town. And from there he went on to practice as a family doctor and as a district surgeon in a township near Cape Town for some 12 years. He was awarded the Harvard South Africa Fellowship and obtained an MPH from Harvard University in 1988. And then in 1996 he obtained a DPhil in epidemiology after receiving a Nuffield Research Fellowship to further his studies at the University of Oxford. In 2014 he was elected as a Fellow of the Royal College of Physicians in Edinburgh. So quite an international background. Professor Volmink has a special interest in evaluations of the effects of healthcare interventions, research capacity building, and the promotion of evidence-based decision-making. He has some 180 scientific publications to his credit, of which 107 were peer-reviewed, and his research has been extensively cited in the scientific literature. He's regularly invited as a speaker at national and international conferences, so we're very lucky to get him here this evening. He's been a member of committees and advisory boards of a large number of international organizations, including the WHO, the UNDP, World Bank, WHO Special Program for Research and Training in Tropical Diseases, the Acumen Fund, the Cochrane Collaboration, the Wellcome Trust, the Vienna School of Clinical Research, the Belgian Red Cross, and the International Clinical Epidemiology Network. And in 2005, he was guest editor of the British Medical Journal special issue on Africa. So with that formidable background, Jimmy has decided on a title for this evening's lecture, which I think was devised simply as a tongue twister for whoever had to introduce him. The title is The Ecstasies and Agonies of Evidence Synthesis. So I nearly got that. Anyway, would you join me in welcoming our speaker this evening?
Good evening, everybody, and thank you very much for coming out in this cold, wet evening to join us for this lecture. James, thank you very much for your kind introduction. I'm very honored to be here this evening to give this lecture. I know what an honor it is to present a Leverhulme lecture because I've looked at the previous speakers you've had in the series and I realize that I'm following a number of luminaries and so I hope that I shall not disappoint you this evening. I'd like to also thank the Liverpool School of Tropical Medicine for not only honouring me in this way, but for your support. Over the years, I have been an honorary fellow at the school since 2001, and I know that I probably have not done enough to deserve that title, but hopefully my lecture tonight will make up somewhat for the deficits of the past. The Leverhulme Trust, I am very grateful for the support of the Trust for me to come here this evening to deliver this lecture. And then I particularly want to say thank you to this gentleman, Paul Garner, with whom I've been associated for 20 years. I remember doing my first Cochrane review under his tutelage 20 years ago, and since then we have continued to work together very productively, and I greatly admire you, Paul, for the work that you do internationally, for the wonderful methodologist and clear thinker that you are. And over the years, we've moved from just being colleagues working together to really being very good friends. And I've enjoyed that and look forward to continuing to work with you. Through Paul, the relationship between the school and people in the school, and there are a number of you here this evening that have become colleagues and friends, this relationship has been cemented with a number of institutions in South Africa, including the South African Medical Research Council, Cochrane South Africa, which is based at the council, and the University of Stellenbosch, which is where I spend most of my time these days. And then from those bases, really also working with people in other institutions, not only in South Africa, but also in many other countries in Africa. I'd particularly like to thank those of you who have come to this lecture, especially those that have come from afar. Many of you have come from other places in the UK, and I particularly appreciate you taking the time. It's a great honour for me that you have done that, so thank you for that. So just to say a few words about somebody that I think you all know about and know of, which is Lord Leverhulme, who was born William Lever, and as you know was a successful businessman, established Lever Brothers, and the company was became quite famous worldwide for the production of soap and other cleaning products. So he was a very special man. Not only was he rich, but he was also very generous, and I think he had great concern for the welfare of his workers. So that's the other thing I discovered. The third thing I discovered was, I asked myself, why Leverhulme? And I discovered that he had in fact chosen Leverhulme in honor of his wife, who was, I think, Elizabeth Hume, and so brought those two names together, which is reflected in his title there. So that was quite unusual for the day, that somebody would take on the surname of his wife. So that's another reason to respect him. And the third, last thing I wanted to say about him was that he did seem to have some idiosyncrasies, one of which was that he believed in sleeping outdoors, come hell or high water, in the cold or in the rain. He used to sleep outside. It's not surprising that he did succumb eventually from pneumonia, but anyway, I'm sure there's much more to it than meets the eye. What I thought I'd do is, as I thought about him, I thought, you know, what are the contact points between me and Lord Leverhulme? And so I wanted to just highlight a few things that I think connect us. The first is sunlight soap. So there is me at 4 years old. Notice the tie at 4 years old. And I grew up with sunlight soap, and you can see how clean and nice I am there. So I was not a stinky 4-year-old, thanks to Lord Leverhulme. So that's the first point of contact. The second is, I like this picture because for me this is a perfect picture of inequality in the world. So there is somebody being fed and somebody being stamped on. And I think during Lord Leverhulme's time, it was also a time of great inequality in Britain. And there was a lot of unrest. There was a lot of fighting for basic human rights. So, for example, the suffragettes here were fighting for, votes for women. And so fierce were they that I believe that in one of their marches, they actually burnt down one of the homes belonging to Lord Leverhulme. So that was interesting. And I think that connects me. Because when I grew up, I didn't have the vote. And so there was a struggle, and I was 30-something before I had the vote. My parents, my grandparents didn't have a vote in South Africa. And I went through the struggle for freedom in South Africa with Nelson Mandela, as you can see here, declaring victory. So I thought that was sort of a synergy there. But of course, the struggle for equality continues, not only here, but also in South Africa. And at the moment, there are student protests around the country for access to more equitable higher education and other issues, social issues that they're fighting for. And so the struggle continues. In fact, I was very pleased to have this invitation to come here because it was an escape from the students that were holding me hostage in Stellenbosch. The last thing that I want to say by way of connecting me to Lord Leverhulme was, I've loved this quote that I found. He says, "Half the money I spend on advertising is wasted. And the problem is I do not know which half." For me, that reflects the fact that he grappled with uncertainty and he disliked waste. And that really is the point of departure for those of us who are working in evidence-based healthcare. And some of our colleagues put together this article in PLOS Medicine recently, or a few years ago, where I think kind of just states this more simply. It says, wherever healthcare is provided and used, it is essential to know which interventions work, which do not work, and which are likely to be harmful. This is especially important in situations where health problems are severe and the scarcity of resources makes it vital that they are not wasted. So I think that's a nice connection with the kinds of things that occupied Lord Leverhulme's mind. So what am I going to talk about this evening? I thought of reducing it really to a personal account of my journey over the last 2 decades, and really to look at 3 questions. What has been my experience of working in this field? What are the major lessons that I think I've learnt? And lastly, what do I think about challenges ahead in terms of achieving this state of the world where decisions are based on good evidence? So if that's okay with you, we'll proceed with that agenda from here on. I must, however, take you back now 20 years ago. So I had good fortune of having a scholarship to do a DPhil in Oxford. And here I am on my bicycle with my son, which I think was about 2 years old or so at the time. And I was cycling very slowly down a little road called Middleway. And coming up in the other direction was a gentleman. And I was going very slowly, and when I passed him, he started talking to me, greeting me very warmly, and started engaging, which I almost fell off the bicycle because this was Oxford. I didn't expect people to do this sort of thing. So, but he was a very kindly gentleman, and he welcomed me to Oxford, had a nice conversation, talked about my son, talked about everything else, and then in the end, said, I work over this building, so maybe I could tell you what I do sometime. Come and visit me, have coffee, we can talk. He turned out to be Ian Chalmers. So Ian is in the audience this evening. I can't find him now. There he is. So thank you, Ian, for coming all the way to this lecture from Oxford. So he was the man, and I did take up his offer to go and visit a few weeks later, and he talked to me about the importance of evidence and making evidence-based decisions. And I think within the first 10 minutes, I was convinced this was the most important thing I could do for the rest of my career, to work in this field and build the evidence base for people to make good decisions. So thank you, Ian, for that. A few years later, early 1997, we started the first Cochrane Center in Africa, the only one at the moment. It remains the only one at the moment. It's the South African Cochrane Center. And on the picture here, you see that's Ian, of course. This is Les Erwig, who's also a South African, working as a professor of epidemiology in Sydney. And this is Merrick Zorenstein, who then worked at the Medical Research Council in South Africa. And so we together, joined forces, and we launched the Cochrane Center. And so there's been no looking back since then. We're still going strong. It would be remiss of me, however, not to mention somebody else who wasn't really part of the establishment of the Cochrane Center, but this is Justice Hofmeyr here, and his research midwife, Cheryl Nicodem. And Justice had worked with Ian Chalmers for, 10, 15 years before then, worked on the Oxford perinatal database, worked on establishing the pregnancy and childbirth group and doing systematic reviews in that field, working subsequently on projects like the Reproductive Health Library and so forth. So he was a great ally in the country and continues to be a great friend. In fact, he's just joined Stellenbosch University and is now working more closely with us there. And so he's been a great supporter. So I just wanted to honor him as well in this introduction here. So fast forward now to 2015. Where are we at in terms of building up a collection of Cochrane reviews that are relevant to Africa? Well, we've gone from a state where we had virtually no Cochrane reviews done by people in Africa. This is the number of Cochrane authors in Africa, to close to 600 authors now in Africa over this time. Where are they situated? Well, they really are, it's quite a spread. So South Africa here, Nigeria, Uganda, Kenya, and a number of the other countries are involved where we have Cochrane authors doing things. And I should also point out that there are many countries where we don't yet have any Cochrane authors, and we're concerned about that. We continue to work on getting more people involved. So quite, I think quite a big achievement over the last several years that we're very pleased about. What I want to stress this evening is that this achievement is a credit to a number of different people. Most of them in Africa, but also people in other countries, working together and being totally committed to building up the capacity to do this evidence synthesis work in Africa. And without them, this could simply not have been done. Many of them have worked as volunteers and have really applied their minds and given their time to work on reviews and building capacity for reviews in Africa. This is just a picture of our 10th anniversary we had. All of these people are Cochrane authors. This is a picture from Nigeria where we have a branch, and this is also a contributors meeting in Nigeria. Then we have the 15th anniversary of Cochrane in Africa that we had more recently. The only thing that bothered me about this picture was that the amount of food doesn't seem to correlate well with the amount of people. I was a bit worried about that. And of course, here you can see perhaps that it was not all work, but some fun and games with lots of cuttings of cakes along the way. Right. That said, let me now get really to the meat of this talk. The first thing I want to say is that over the 20 years or so I've been involved in evidence synthesis, the terrain has changed a lot. Things used to be a lot simpler when I started. It's a lot more complex now. So what has changed? First of all, the number of systematic reviews produced annually in literature has really grown from about 80 to about 8,000. And Cochrane reviews now constitute maybe a quarter or so of all those reviews. So that's the picture. A lot of people are doing these reviews now. The second is that while initially our work focused a lot on clinical trials and looking at the effects of interventions, now there are a lot more syntheses of other types of studies, observational studies looking at diagnostic accuracy or prognosis, qualitative studies, as well as animal studies. So systematic reviews now being done on a range of different topics and using a number of different designs. So that's different. The third is a move towards greater prioritization of topics. Initially in Cochrane we used to, anybody could just come up with a title and you'd be supported to try and do your work. And some of the, the work that was done was quite resource intensive. So by doing Cochrane reviews on topics that are perhaps not of global importance, you're actually not able to get to the important topics that affect lots of people in the world. So there is a move towards saying what are the priority topics that we really need to have good evidence about, and let's focus our scarce resources on that. The dramatic expansion of methods, I think is really quite important. I mean, just understanding the sources of bias, trying to measure or detect the kinds of bias, the methods around that has changed, the statistical methods have moved on. The presentation of the information for decision makers, use of grade tables and all of those things are fairly new, and all of those have developed over the last 2 decades. And the thing that I wanted to focus more my attention on this evening is really about what impact we have had on policy and practice. And I think over the 20 years I would say that the impact has increased. However, it still remains quite variable and it's difficult to predict how evidence will be used, and maybe that will always be the case, but I think it's worth noting how that goes on in the world, and I will say much more about that in the next few minutes. So if you're not involved in this field, I suppose one might say, why bother? Why do you want to spend all your time synthesizing evidence? And I think that I spoke to you about the 10 minutes in Ian Chalmers' office, which convinced me about the direction I should take. And I think he, in this article, as perhaps more eloquently than I could ever imagine, presented the case for good work on evidence synthesis. It is the business of policymakers and practitioners to intervene in other people's lives. Although they usually act with the best of intentions, their policies and practices sometimes have unintended, unwanted effects, and they occasionally do more harm than good. That was quite a revelation for me, when I started this process. This reality should be their main motivation for ensuring that their prescriptions and proscriptions for others are informed by reliable research evidence. And the understanding that reliable research evidence really involves not cherry picking certain studies to make your case, but to look at the totality of evidence and to look at the quality of the evidence you're dealing with, and to present the full picture based on the most reliable research that has been done. That really is what is meant by reliable evidence. Now, how can this evidence then be translated into practice and policy? Well, evidence will tell you different things. Evidence can go one way or the other. So here are a few scenarios. The first being, an intervention could be shown to be ineffective or be harmful. And the logical thing to do here would be to abandon such an intervention if it's already being used, or to avoid using it in the first place. The second is that the intervention might be shown to be effective and safe, in which case you might want to continue that or implement that. Then you could have a situation where there's some benefit and some harm, but you have to balance two or more interventions to decide which one you want to pick, because none of them are perfect, but there is some effect, and it makes sense to use one or more of these interventions. So in that case, you would argue that let's choose the best, the one that you can afford, and offer that. And then, of course, unfortunately, we're often in a situation where the effects of the intervention is actually not clear at all. And in that case, you shouldn't really be offering that intervention except in a situation of research or trials where you're establishing the benefit of that intervention, and then that moves you back into the evidence base. So that seems like a logical sort of framework for deciding how evidence can be used. But logic, of course, is problematic in the real world because decision making is messy. And I like, this is an anthropologist who comments on the use of evidence, that the notion that right-minded people will naturally make decisions on the basis of the best available evidence is a misleading and dangerous idea. So people don't use evidence in the simplistic way I've presented to make decisions. Why is that? Because evidence is really only one ingredient or input into the decision-making process. People are influenced by lots of different things other than evidence. So very often strong beliefs about something, that it's effective, that it works, or because I like to do it, will drive a decision to use that intervention. Or theories about how things might work gets conflated with evidence that something actually does work, and those are two different things. Vested interest, either politics or commercial interests, and sometimes even academic interests, can affect the way one makes decisions and lead to maybe errors in making decisions. Values and ideologies, habits that you have, knowledge, attitudes and skills, and of course structural issues like financial constraints and so on, can all affect the way that you use evidence. And so under the weight of all these influences, sometimes evidence gets ignored, simply ignored, and used very selectively at best. So let me present just a few examples. A debate in the US about guns and violence. And here is an American congressman very seriously in Congress says, guns have very little or nothing to do with violence. The causes of youth violence are working parents who put their kids into daycare, the teaching of evolution in the schools, and working mothers who take birth control pills. So, it just seems outrageous, but this is an otherwise perfectly rational person who makes this sort of evidence-free comment. And that does happen. So let me not bash the US, let me bash South Africa for a while. And I've left the UK, I didn't want to bash you in respect of the audience here, but I'm sure you know of similar examples here. So this is a situation where big HIV/AIDS epidemic in South Africa, and the Minister of Health and the President refused to adopt antiretrovirals, focusing on nutrition. And the Minister of Health says nutrition is the basis of all good health and can stop the progression of HIV to full-blown AIDS. And eating garlic and olive oil, beetroot, and the African potato boosts the immune system to ensure the body is able to defend itself against the virus and live with it. Okay, pretty serious, with 800 people a day dying of HIV, hearing somebody say that. So, this happens in the real world. This is the real world, okay? Of course, we're all familiar with celebrities and how knowledgeable they are about health issues. And here is somebody saying, psychiatry doesn't work. When you study the effects, it's a crime against humanity. And so we all know of celebrities who are authorities on various subjects. And often there is no evidence base at all to what they're saying, but people follow them because they're popular, they are celebrities. And that brings us to the World Health Organization, a respected organization where you would expect that people would be making good decisions based on the best available evidence. And Andy Oxman and co. here published this work in The Lancet, which shows that the old habits of basing decisions on expert opinion continue. And so this was published in 2007. He says systematic reviews and concise summaries of findings are rarely used for developing recommendations. Instead, processes usually rely on experts in a particular specialty rather than representative of those who will have to live with the recommendations, or on experts in particular methodological areas. So this was a bit of a bombshell. It was dropped, and to the credit of the WHO, they have taken this criticism seriously, and I think there have been since then very serious attempts to try and ensure that their guidelines are based on evidence more and more. So that's work in progress, but I think there have been improvements in this regard. So to come to the agonies and ecstasies. So I thought of perhaps just using 4 examples from my work and the work of others that I've collaborated with to illustrate perhaps the process and also the lessons that have been learnt from those specific examples. So you will forgive me if these examples are very personal, but these are the ones I know the best, and I wanted to talk about those. So the first issue is around directly observed therapy for tuberculosis. As many of you will know, directly observed therapy is something that has been very dear to many hearts in the TB control world for a long time. In fact, the TB world is, as Metcalf here has commented, is filled with lots of very committed people who have fervor for certain things and they promote it very strongly. So he says, DOT in TB treatment has become enshrined as canon in a field long characterized by fervor in principle and practice as no other disease. And this was this week, I went to the website of the Centers for Disease Control in the US, and this is the statement that I found. You'll see at the bottom here, DOT is the most effective strategy for making sure patients take their medicines. DOT means that a health worker or other designated individual watches the patient swallow every dose of the prescribed drugs. DOT should be considered for all patients because it is difficult to reliably predict which patients will be adherent. Keep in mind there are 8 million people falling ill with TB around the world. Can you imagine all of them being watched as they swallow their medication? That not aside, I think that there is still this very fervent commitment to directly observed therapy, particularly in the US. That influence was spread to other parts, including Geneva. And so in 1997, the Director General of the World Health Organization, he put out this press release which was covered in most of the major newspapers around the world, where he made several claims. Number one, DOTS program is the biggest healthcare breakthrough of this decade. 2, it's the single most important development in the fight against tuberculosis since Robert Koch discovered the TB bacillus in 1882. And thirdly, that there is overwhelming evidence for the effectiveness of DOT from studies in the USA, Asia, and Africa. That troubled me. When I read that, I was actually in Oxford doing my DPhil on a completely different topic. But I read this and I was really worried about it. So I looked up exactly what this was about. So the WHO DOT was a 5-point strategy involving political commitment, improved laboratory analysis, direct observation, short course drugs, and reporting system that is improved. But that was the picture they presented, but the emphasis was clearly on that yellow bit, which is direct observation. They were really pushing that as the key, and that was the piece that they claimed was supported by the evidence from around the world. Coming from a country that had a lot of tuberculosis, I was aware that, first of all, there is a problem expecting poor people to come to a clinic every day to have somebody watch them swallow their medication. I was concerned about stigma in some cases of people having to present themselves in this way, knowing, revealing the fact that they had TB and the impact that might have. The reduction of patient autonomy. I saw this as a very coercive kind of approach to dealing with a problem. And those were the reasons that I started looking at, I did a quick and dirty and looked at, so where is the evidence coming from? And I couldn't find anything. And at that stage I went to Ian Chalmers and I said, Ian, I've got this burning question. I really would like to know whether DOT works. And he said, oh, you should meet Paul Garner. And he, of course, introduced me to Paul Garner, and that was the first Cochrane review that I did so many years ago to look at what available evidence there was at the time. So what we found was that there was actually very few trials around, and so we looked beyond DOT. We said, can we find good evidence for any adherence-promoting intervention for TB? And to our surprise, there were only 5 published trials in the world on the subject. There was some evidence from these trials that default to retrieval actions, patient incentives, health education, staff supervision, these are some of the interventions that had been shown to work in trials. But importantly, there were no trials of direct observation, not one. And so we couldn't understand where these claims were coming from about good evidence. We published this work, both I think in the BMJ and in the Cochrane Library at the time, and the letters came flying in from WHO and others. They were mostly critical. For example, people were saying, I don't think it is productive to present a message that DOT is not effective. These debates are truly not useful, especially to the field workers in countries where DOTS is implemented and needs to be expanded rapidly. In fact, I was called into the office by the head of the TB control program in Geneva when I was there for some other reason, and I was given a good scolding about how dare we challenge this because we're making life so difficult for them in low and middle income countries. And that other letters were saying that there is proof, but it's from observational studies. There were also many written and verbal attacks on the competence and characters of the researchers involved in the work, which was not that easy to deal with, but there it was. But what was interesting was that there was also a lot of private correspondence we were receiving from people around the world who were looking after, caring for patients with TB, and said, "Oh, we're so pleased you did this. We think this is a ridiculous, approach to dealing with the problem, and we're very pleased to hear that there is no evidence to support it. This was really helpful to us." But they wouldn't do that publicly, but they wrote to us privately about that. So that was also very interesting. So the next step was for us to, since there were all these claims about proof from observational studies, we said, well, then maybe we should look at the observational studies, see what is available, how good are they, etc., etc. But also, we realized at the time that there was a bit of confusion about what we're talking about when we talk about DOT. Different people use the word in different ways. And so we also wanted to define exactly what DOT involved in the different studies that evaluated the program. So we found 32 studies. They were mostly observational, mostly without controls. And almost all of them concluded that DOT was better than self-supervision, self-administered treatment, for improving adherence and or cure rates. Okay, so universally they said that DOT works. Yet when you looked at the studies and you looked at the programs, in addition to DOT, there were so many other things going on. So in all of these programs, there was extra funding being pumped into the programs, there were more trained staff, there were incentives being provided, more education, social support, defaulted tracing. and even in one program, free cigarettes as an incentive to complete your TB treatment. That is rather rich, but yeah, that was true of one of the programs. And so we looked at this and said, how could anybody conclude that DOT was actually making the difference? That there's so many co-interventions, and from these studies, it was impossible to say whether DOT had an independent effect. And we published that work as well. So that was another thing we put out there and was very unpopular. But the third thing we did was we said, well, let's, as a next step, start looking at what are the factors that influence adherence to TB treatment. We thought we could do this best from qualitative studies, where people had been interviewed, and other types of qualitative studies have been done with patients, with their carers, with health providers, and let's put all of that information together. And so we found 44 studies that looked at factors associated with adherence. And we kind of stratified them into structural factors like poverty and financial burden, personal factors, health service factors like how healthcare is organized, and then we also pointed out the social context around the family, community, household influences. These are all important issues that ultimately influence whether or not you complete your medication. And the point we were making here is that all of these areas would be possible targets for interventions that could be developed to address them and therefore to improve adherence. So that was our third angle on this issue, using evidence synthesis. So we were delighted that over the next 10 years, a number of trials were being conducted, not only on DOT, but on a number of the other areas that we thought were important as well. And so in our Cochrane reviews, we've now split the DOT review, and then we have a separate review for every type of intervention looking at adherence to TB treatment. But what I'm showing here is what we have found with the trials. So there are 10 trials. I think there are 1 or 2 more now because this work has been updated recently, that have compared directly observed therapy with self-supervision. Our conclusion from this was that the results of randomized controlled trials conducted in low, middle, and high-income countries provide no assurance that DOT compared with SAT treatment has any quantitatively important effect on cure or treatment completion in people receiving treatment for tuberculosis. And you may not be able to see this very well, but you can see these estimates are all hugging the line of no effect there. And so there's virtually no evidence that DOT is an effective intervention to improve adherence. And so what we started talking about more and we started writing about are the following points. We made the point that DOTS as a term is unhelpful, because it actually focuses specific attention on that element of the 5-point strategy for which there is no evidence. We thought that the strategy should be revised by WHO. We thought that there was some evidence that other interventions, as shown here, were valuable and should be considered in TB control programs. And that the issue of funding, of course, must be kept on the agenda, because that does make a difference in terms of how effective the program can function and deliver in especially low and middle income countries, but also elsewhere. So those are the points we were consistently making at the time. So what I want to show you now is, I've already shown you this bit here, which is WHO DOTS definition in 1997. If you go to the WHO website now, and you look at what the strategy involves, it's still a 5-point strategy, but I want to challenge you to find DOTS anywhere here, or DOT. It was there before. Now it's no longer there. In fact, it's been replaced by this one, which is standardized treatment with supervision and patient support. So what happened to DOT? Well, it's deeply buried in the WHO website, and it's a much more nuanced take on DOT. And it says, services for TB care should identify and address factors that may make patients interrupt or stop treatment, supervise treatment, which may have to include direct observation of therapy, helps patients to take their drugs regularly and complete treatment. We think this is much more nuanced, much more close to where, much closer to where the evidence is. And so I think that, you know, I respect WHO for making that change, and I think it's a good thing that they are adopting the evidence at hand on this issue. So what are some of the lessons very quickly from this example? The first is that we believe that the evidence synthesis work over about 15 years definitely stimulated debate around an important global issue, and we're very pleased about that. People were talking about it everywhere, you know, this sort of tension between dot or not. It also spurred research. We showed that, you know, there were only 5 trials on the entire, you know, area of adherence to therapy in TB. There are many more trials now. We felt that clarifying and communicating the evidence base was a very useful thing to do over time. And we're pleased that there has been some impact on policy ultimately. And then the last thing I think is, you know, just the issue of perseverance in patients. Something that I am very aware of is that people who seem to be making decisions not based on good evidence are not necessarily bad people. So they may, in fact, when presented with the evidence, not like it and attack you. But it's not the right thing to fire back. You just have to be true to the evidence and present the evidence in a clear way possible and stick with it, not back off. I mean, if that's the evidence, that's the evidence. And if ultimately that does change things. So that is an important lesson that we learned in the DOTS scenario, but that also came up in many of the others. Let me move on to the second example, which is antiretroviral therapy for preventing mother-to-child transmission of HIV. Clearly, as I've already mentioned, a big issue in South Africa. So in the early part of the century, South Africa was facing this huge HIV/AIDS epidemic. It's still big, but at least we have antiretroviral rollout across the country, and it's starting to make a huge difference. But at the time, no antiretrovirals were being offered, and they were very expensive, to be honest, at the time. So the MRC commented South Africa is experiencing an HIV/AIDS epidemic of shattering dimensions. What this graph shows you is the antenatal prevalence of HIV, so pregnant mothers here, about a quarter of them being HIV positive, with the vertical transmission rate estimated at around 25%. So a high risk of babies developing HIV infection and dying. And in fact, that year, UNAIDS in 1999 showed that more than 70,000 babies in South Africa were born with HIV infection. Clearly a very, very serious situation. At the time, the South African government was coming under lots of pressure to offer antiretrovirals. Now, you will recall at the time we were talking about monotherapy, mostly zidovudine and what was the nevirapine at the time. And since then, you know, the regimens have become more complex and we use multiple dosing and so on. But, you know, that was the available treatment at the time. For some reason, government refused to offer this, and they were, you know, looking for ways of sort of getting out of it and not doing it. And so they were approaching various people. They had gone to the Medicines Control Council and said, give us the evidence that antiretrovirals work, and MCC came back and said, yes, it does. They didn't like that, and then they came to the Cochrane Center, although we didn't know about the MCC stuff before that. And they said, you know, give us the evidence, do a risk-benefit profile, and come back to us. What we found by looking at a Cochrane review, in addition looking at some animal studies, and looking at other human studies looking specifically at safety issues, we put together a report, we submitted it to government, where we say ART is highly effective in reducing transmission. The benefits of these drugs outweigh risks. There might be some minor adverse effects like anemia in children. It seems to be resolving after time. And we think that ART is effective, is a cost-effective and effective strategy and should be offered. And now, during the time that we were doing this work, we literally got a call from the minister's office every week to find out when the results will be available. When we presented them with the findings, there was complete silence on the other side. They would not, we asked for a meeting to go through the results and discuss the results with them. They would not engage with us at all. In fact, the next year they released a strategy for HIV in South Africa that specifically omitted antiretrovirals, which we thought was absolutely criminal. And we were delighted when there was people, a number of stakeholders, but led by civil society through the Treatment Action Campaign, taking government to court on this issue. And the court ordered government to simply get on with it, that there is enough evidence and that it is a right for people to have the best available treatment and that they should do it. Government still was not willing to accept that, took it to the Constitutional Court, and the Constitutional Court said the same thing and said to government, sorry, you've got to go out there and you've got to do it. And then they accepted it, and finally in 2003, antiretrovirals were made widely available, and subsequently a more comprehensive plan was put in place, including antiretrovirals. This shows here the absolute joy in the community when that victory was won in the courts, and that antiretrovirals would now be available to people in the country. So what has been the impact? So the green bits here shows you the coverage in terms of antiretroviral prophylaxis in pregnant women and babies. And you can see a very nice increase here from around 2003 to 2010 here, where in 2010 is almost 100% coverage in terms of the provision of antiretrovirals. So that was a hard-won battle, a victory, and a very important one to have won. And I think, our evidence synthesis work made a very small contribution, but at least it was put out there for government to consider, and it was used in the court action that followed as evidence that the drugs work. So in terms of impact on transmission rates, I've already mentioned initially before antiretrovirals was around 25% or so, and by 2010 it had dropped to 3.5%, and the most recent survey showed a 2.7%. Still high, but certainly a lot better than it used to be. So, this I believe has been an important issue to have tackled in South Africa, and we could not have done this alone as researchers. It was very important that we, in this case, needed to link up with the broader society. We were asked by the Milbank Foundation to write up what we thought we learned from this experience. And some of the comments, I went back to the article that we made at the time, was that we learned how that evidence can sometimes be eclipsed by political agendas and entrenched prior views. And we always need to be aware of that. That the search for evidence can sometimes just be an attempt by policymakers to bolster their own position. We're looking for evidence, but actually they're looking for evidence to support what they really want to do or do not want to do. And then, as I've already indicated, the teaming up with other stakeholders, especially patients and civil society, which can really lead to some very good and positive results. And I think researchers often don't use this. I think we need to work more with patients. We need to work more with civil society to take to get decision makers to do the right thing, especially political decisions. That brings me then quickly to the third example, which is also in the field of HIV infection. In this case, it's male circumcision. So the question here was that, this is sort of around middle of 2002, 2003. The epidemic was really biting very deep in Africa, and it was desperate, and antiretrovirals were still not widely available, largely due to cost at the time. And so people were really desperate to find ways of doing anything to stop this epidemic. And so there was a lot of pressure from funders and policymakers to do something. And the feeling that we can't wait for trials to be completed. Just tell us what to do now. What can we do now? And so we knew at the time that there were trials that were ongoing, clinical trials of male circumcision to prevent acquisition of HIV. And so we thought maybe we should wait for that. But we consulted with some of the international stakeholders, and they said, no, please just get on with it. Just give us the evidence from whatever information you can find. And we then proceeded with that, and we found 35 observational studies where we thought we could find some evidence on the question that we were interested in. This one, fortunately, was the picture. So from the cross-sectional studies, we found that male circumcision really was equally likely to be shown to be effective as harmful. So it was spread around the line of no effect. So it was really very difficult to draw any conclusions from that. However, in a subset of high-risk individuals or high-risk groups, there did seem to be some indication that circumcision might, in fact, do something in these people, so we did show that. We did feel a little bit uncomfortable drawing firm conclusions because, being observational studies, there were so many other factors at play that could confound these results. So our conclusions was basically that confounding as an explanation of the findings could not be entirely ruled out. We were worried about that. We thought that the current evidence does not provide sufficient grounds for implementation, and that the results of the RCT should in fact be awaited. Well, the results eventually did become available, and there were 3, and there probably will only be 3 ever, because all 3 of them were stopped for benefit. Prematurely stopped for benefit. And all 3 of them showed a very strong effect. So this review shows strong evidence that medical male circumcision reduces acquisition of HIV. And from that, we felt that, based on this evidence, we shouldn't hesitate to recommend that this be used as part of the armamentarium for prevention of HIV. So what were the lessons from this example? Well, firstly, that we reflected a lot, because we spent a lot of time looking at the observational data, and they're not easy to look through because of so many factors you have to take into account. And we asked ourselves, was this really worth the effort? Because we couldn't make any decisions based on this. Well, we felt that maybe it was useful, because at least it advanced the debate around evidence-based decision-making, what it means for an important problem like this. We put that evidence out there. There were lots of presentation at conferences around it, whether or not this evidence is sufficient or not. The community was really quite divided on that. Although there were people who felt very strongly from the outset, before these reviews were even done, that this is a good intervention. But it also strengthened our relationship with WHO and UNAIDS, and we felt that that was important not only for this topic, but for future work that we were doing. So we felt that perhaps on balance, it was worth the effort. But we asked ourselves, was this policy driving evidence, or was this evidence driving policy? And we couldn't figure out. Maybe both are necessary sometimes, and we just left it there. Let's come to the last example that I wanted to mention, and that is about a BCG booster vaccine called MVA85A. And this is a most recent example. This was a trial recently published in The Lancet, which, so as you know, BCG is the sort of standard vaccine for tuberculosis. It doesn't work very well in most situations. And so a booster has been developed, a booster vaccine, to be offered alongside BCG to improve its efficacy. And this trial actually showed no benefit between BCG plus booster versus BCG alone. And so the question then was, well, was there any reason to suspect that this booster would be effective before this trial was done? And what the evidence, what the literature was showing is that there were lots of strong claims from animal studies that the booster vaccine was indeed protective, and that was the basis on which, or at least one of the driving factors for doing the human trial. And I should just point out that this human trial was done in South Africa with researchers from University of Cape Town and Oxford University. And it was done in babies in Cape Town, and there were 3,000 of them in the study, almost 3,000 of them in the study. So it was a major, still the largest trial of this vaccine, and it showed no effect. So some people started asking the question, well, what evidence did we have from the animal or preclinical studies that this booster would in fact be effective? I mean, there were these claims, but what was the evidence? And so a group, Rufaro is an MSc student at Stellenbosch, working with some others from Stellenbosch, Liverpool and Edinburgh. They got together and they did a systematic review of MVA-85A looking at the animal studies or the preclinical studies. What did they find? Well, the first thing they found was that there were 8 preclinical studies to date of 192 animals. Quite worryingly, they showed in this review that studies were largely underpowered and lacked internal validity. So they didn't appear to be of good quality. They were badly reported. They didn't follow approved guidelines for how one reports on animal studies. They didn't, for example, report on sample size or power calculations. Few of them were randomized and or blinded. Importantly, from the synthesis of the preclinical studies, there was no evidence of efficacy from the animal studies, contrary to the claims that had been made. And then there was one other worrying factor. The review found that the largest animal study with the longest follow-up was published almost a year after the trial in South African babies had started, though it had been done prior to the trial being done. And in this study, 5 out of 6 monkeys who received the booster vaccine plus BCG died, compared to 2 out of 6 in the control receiving only BCG. So more babies died with the booster vaccine. The difference was not statistically significant in this instance, but still, looking on the face of it, this is a worrying sort of picture, and something that, you know, I think people who approved the trial should have been aware of or acted on in terms of making that decision. So this was a synthesis of a different kind, and I think it provided some important lessons. The first, I think it illustrates that evidence synthesis can be very important for highlighting shortcomings in the conduct and reporting of animal studies, and should be encouraged for animal studies as much as it is for human studies. That it is important to have this very rigorous approach to evaluating benefits and harms claimed for animal studies. I think related to that is the importance of the independent assessment of evidence. You know, people who conduct trials should not be the same people who tell you, you know, what the results are or whether an intervention works or not. It's useful to have an independent group looking at the data, interrogating the data, and drawing conclusions. And then there's the issue of transparency. So I raised the issue of that one trial where it seems to be pointing in the direction of harm. And yet, we are not sure at this point whether the ethics committees in South Africa or in the UK were aware of those results. In fact, more work is being done at the moment by some people in this audience who are looking at following up on this and trying to tell the story about what happened in this case. So it's an investigation that is ongoing. I want to conclude now with just a few comments. I promised you that I would reflect a little bit on challenges ahead and what needs to be addressed. So evidence-based policy for global health, what do we need to be mindful of as we go forward? We presented this sort of flow chart and barriers to evidence-based practice in a recent publication, and I thought I'd draw from that. So looking at the top, we talk about the importance of primary research relevant to low and middle income countries being needed. We talk about systematic reviews of that evidence, which follows. The third aspect is scientific evidence must reach policymakers. They must have access to the evidence. Then the policymakers must value the evidence and use it. And then finally, policymakers must implement effective interventions on a large scale, and that's a different story. So looking at those steps, we try to identify some barriers to evidence-based practice. And I'm just going to summarize it very quickly by saying we desperately need more primary research in low and middle income countries. Currently in the literature there is a geographical and cultural bias in evidence from primary research. There are lots of topics that we engage on in systematic reviews where we look at important questions for developing countries and we find no studies or very few studies that tell us anything about it. A recent paper in PLOS One said that, in fact, had a few people look at this issue and they revealed some statistics which I think was quite sobering. They said 99% of HIV death occurs in low and middle income countries, yet only 31% of trials are done in developing countries. For tobacco deaths, 70% of tobacco deaths now occur in low and middle income countries, and those countries account for only 4% of randomized trials. So you can see that there is this complete mismatch between the global burden and where the research is being done. So primary research, absolutely needed. The second is that there are too few systematic reviews that address topics that are pertinent to low and middle income countries. And although I think in Cochrane things have improved, I think we've got a long way to go in presenting that balance, tackling really important issues affecting people around the world. And I think in particular, I feel that this can be best addressed by actually continuing to build capacity for people to do synthesis work in developing countries, and I think it's important that we continue that work. The third thing, the third challenge, I think, is the question of access. So you know that most of the literature is still locked away behind very costly access barriers. And that is a shame. And there are also copyright licensing regulations that prevent people from accessing that information. In terms of Cochrane, I think the Cochrane Library is now available. It's accessible to, 3.5 billion or so people around the world, mostly in low, free of charge to people in low-income countries. And Cochrane is working on rolling out over the next few years an open access policy that will eventually make Cochrane reviews widely available. But I think other data, other information should also become more and more available. Then there's the issue of whether policymakers use evidence. And we've already talked quite a lot about this. So I would just say that in our experience, what we're finding very often with policymakers is they don't necessarily know how to use the available evidence. And I think there's some scope for helping people understand and interpret evidence. I think there is the issue of relevance of that evidence, and of course there are the competing factors which cause people not to adopt the evidence, and all of those require to be looked at more carefully. Finally, I think there's the issue of scaling up. So just because you have an effective intervention shown in a trial, that's necessary, but it is not sufficient for making a difference. And from there, you need to have a whole process of scaling up the intervention. For example, how does one roll out antiretrovirals to everybody in South Africa or other countries, to people who have HIV? It's not as easy as you think it might be, and so there are factors that are barriers and some facilitators to such rollout programs, and we need to better understand those, and I think operational research around that issue is absolutely essential. So for me, those are the 5 areas that I think we probably should focus on. I think we need all of them. We can't be selective, but not everybody can work in every area, so you have to decide. Okay, so fortunately, I think things are coming together very nicely around the evidence synthesis work and the subsequent implementation work, and that's through knowledge translation. This is an exciting area. It's been described by the Canadian Institute of Health Research as the exchange, synthesis, and ethically sound application of knowledge within a complex system of interactions among researchers and users to accelerate the capture of the benefits of research for patients through improved health, more effective services and products, and a strengthened health system. So connecting the evidence to the implementation is what this is about. It needs people with different kinds of backgrounds and expertise. A range of different disciplines are required to make this happen, and I think it's an exciting time for us to look for new ways of collaborating across our disciplines to make all of this happen. And ladies and gentlemen, I will therefore close by saying that, looking back on my 20-year career so far on evidence synthesis, I would say it has definitely been very rewarding. It's been personally very satisfying. It has, I believe, working with other people and seeing, that, we can have an impact, that we can help to address global health priorities through providing good evidence, even though that evidence may not immediately be taken up, I think has been exciting. So we have succeeded in influencing policy. I think personally I've learned much, and I continue to learn much about this very complex process of not only synthesizing evidence but helping to get it adopted. And I look forward to much more of this in the future. And then I should just acknowledge my many friends that I've made around the world, including Liverpool. And it's just been absolutely wonderful to meet people of your caliber and to really be able to think together, work together, and help to improve the world just a little bit. But of course there have also been some enemies that have been made. Hopefully we'll turn that around in future. Thank you very much for your attention.
I think I know you're amongst friends here, so we can't let you off the hook without the opportunity.
The exit is right here, Bryce.
Yeah, that's right. I got somebody blocking the door there. Right. We've got time for a few questions, so could you indicate when you'd like to ask a question, because we've got microphones either side, and that'll help a lot. Yeah, start away there.
Hi there. Can you hear me without the microphone?
I can indeed. Yeah.
If I use it. You discussed there at the end how policymakers can have difficulty in understanding and using the evidence that's produced from evidence synthesis, and also issues surrounding relevance. And I remember right back at the beginning, you mentioned how production of systematic reviews has increased 100-fold over the past 20 years. And I wondered whether you thought there might be a risk there of flooding the scientific landscape and making it actually even harder for policymakers to work out what is relevant and to use that in developing policy? I
think that's really an excellent point. I think today the literature is being flooded by lots of people doing systematic reviews, not necessarily following similar methods, some better than others, and reaching different conclusions. And so that remains a challenge. And so I think part of the engagement with policymakers is helping them to also be able to critique systematic reviews so that they understand what is a good systematic review and which ones can they believe and which ones they should be doubtful about. So it's, you know, it is unfortunately something we can't stop. It is going to happen. But what we can do is to try and help people understand better how to use the evidence and which evidence is good or not.
Thank you.
Other questions? Yes, here.
Yeah, I could probably talk without a microphone.
As long as everyone else can hear as well.
I can see the lack of evidence synthesis as a big problem, but isn't the bigger problem that there's a lack of high quality evidence to synthesize coming out of Africa?
Yes, yes.
I mean, your BCG example, 10 trials, 12 trials, why does it take that many trials for us to understand what is going on?
Yeah. So, are you referring to the lack of primary research?
The lack of primary research, particularly lack of trials. You know, I think the evidence synthesis goes on, but it's the high quality trials that are really lacking.
Yeah, and indeed, systematic reviews are only as valuable as the primary research that it looks at. I mean, I think it's really necessary to scale up trial work in Africa. I think, you know, it's a case of who drives the agenda and how, you know, who can influence funders to look at important questions and who decides on what the questions are. And so let's take nutrition, for example. It's a huge issue, right, in low and middle income countries. But if you look at the nutrition trials that are there, the vast majority of them are supplements. And that's driven by a commercial agenda, right? And there are many other issues that we need to be looking at in terms ranging from food security and how to improve it to, you know, diets and, you know, different types of things people eat that are not supplements that need to be looked at. But, you know, there's a paucity of data around that because it's not sexy. It's difficult to get people to support that because of who drives the agenda. So I think it is a problem. That being said, I think there are organizations that are trying to make an impact here. And I think the one that I know best is EDCTP, who have actually committed themselves to increasing the number of trials done in Africa. They are selective in terms of the topics they cover, so HIV, TB, malaria, but those are important issues as well in Africa. So I think we've got a long way to go. I think we need to get bigger funders to mobilize resources for us to do trials in Africa. There are a lot of people who would be interested, but there's not always the funding for it. So absolutely necessary to look at that. And that was number one point on that slide that I showed about barriers.
Yeah, one right at the back.
Thank you very much indeed for a lovely lecture, and I must give you a replacement photograph because I've lost weight since the one that you had there, and I'm very proud that I've lost it and kept it off. I want to ask you a sort of deanly question. You've referred sometimes directly and sometimes obliquely to the variety of perverse incentives there are to do single studies, short follow-up, no collaboration, for all sorts of reasons, both academic and commercial mainly. So what would you as a dean propose as alternative incentives to get people off the impact factor drug, for example, when assessing the way that academic institutions are performing, to get people to submit for publication or reporting anyway studies that have come out with disappointing results? I was hearing in Oxford yesterday that several PhD students had been told that they would not be advised to submit a report as part of their PhD which had been very competently done, addressing a question which needed to be addressed, but because it hadn't come out with a positive outcome, they shouldn't include it in their PhD. Now, such unscientific behavior within academia is really frightening. It suggests that the academia is sick in its very core. So what, as a dean, do you suggest might be done to actually, I know that you show good moral leadership anyway, but what should be done in practical terms to try and reverse this really sad situation?
Do you have any easy questions here? Well, first of all, I must acknowledge that academia is sick. I think the research enterprise is flawed. I think that we're all, on this treadmill, working very hard at getting papers out, as many as possible in high-impact journals, because we are rewarded for that. So I think that part of the problem is, part of the solution, I think, is, first of all, educating people. I think awareness of what it means to behave in this way, what it means to bury certain studies, what it means to focus on trivial outcomes so that you can generate papers very quickly, what that means for science. And I think constantly putting that out there and educating people. But ultimately, it's about the rewards. I really believe it's about rewards. What behavior reward, I think, is what determines that behavior. And so we need to be looking, and I don't have any quick answers to this, but I think an engagement with governments, if there are government subsidies provided to institutions, that they should be linked to rewarding the correct behavior, to try and change the behavior that is currently in place. To look at funders and to see what their role is in encouraging poor behavior in terms of science. So it is really, really trying to, to be quite honest, I think you will agree perhaps that almost everything that's wrong in this world today is related to money as a factor. So, and it's the same with academia, and it's the same with research. It's who pays you and what they pay for that actually determines your behavior. So I think unless we change that, I don't think we're going to change the behavior, and to be honest. I think we also need regulatory bodies to be much more aware, ethics committees to be much more aware than they are of the appropriate way to conduct science and to report science. I think there are a lot of people who are simply not aware. I think in some cases, in some countries, there is a lot more awareness than in other countries. So I think there's a lot that we need to do to educate people. So I don't know I have a straight answer for you, but I think it's around education, and I think it's around incentives that we need to work.
So time for just one more question before we break. That's one there.
If you are a clinician or an academic embarking on a systematic review or a systematic review of data, is it a strength or a weakness to pick a topic in which you already feel you have a degree of specialist knowledge? Meaning to say that when you do have a degree of specialist knowledge, then that informs the context of the review and therefore may influence selection of papers, analysis of findings. But if you don't have specialist knowledge, then it's very difficult to contextualize and understand the problems. So how do you deal with that?
Yeah, thank you for that question. I think that certainly specialist knowledge should not disqualify you from doing a systematic review. I think it can be a strength. But I think what we're finding more and more with systematic review is that you need a balance of participants, experts working together. Some may be more specialist knowledge people, others may be methodologists. And so in working together, so that you sort of, you can balance each other out. If the specialist who believes very strongly, a content expert believing very strongly about something, you might look at the data very differently. But if there's somebody else working with him who's not working in that field, it could correct some of the biases there. So I think it's a matter of who you bring together as a team, and that's the nice thing about a systematic review. It's not one person that is driving this. It's a team of people working together, working often independently of each other, and then coming together to work on this. So I think more and more we need to look at the composition of those teams so that we reach a situation where we can sort of counter each other's biases.
So we're just going to have to bring this part of the evening to a close now. I'd simply ask you to join with me in thanking Professor Jimmy Volmink for a fascinating and very personal lecture this evening. Thank you very much. Thank you. And now I ask Professor Steve Ward to present Jimmy with a medal of the Leverhulme Lecture.
Yes, I've been entrusted for one night only with the Leverhulme medal by Janet. I'd like to congratulate Jimmy on spending a whole career questioning dogma and what is no more than scientific intuition. I'd like to point out he's on very thin ice, at least in some households, questioning Mr. Tom Cruise on his scientific I'd like to thank him for a fantastic presentation, which was insightful and entertaining and very relevant to the activities of the school, for his 20 years support of the school and the Cochrane initiative. And a whole list of achievements were mentioned right at the outset, but the one thing that was forgotten or seemed to be missed was that this gentleman here has been able to remain friends with Paul for 20 years, despite the strange sense of humour.
He just won't let me go.
Exactly. And he's definitely a friend. It's my pleasure on behalf of LSTM to present you with the Leverhulme medal, and thank you for all your contributions to the school and to your seminar today.
Thank you so much. Thank you.
Now we have the opportunity to continue to interact, and there will be people at the back in the corridor showing you which way to join us for a drink.
And the subject of the discussion is academia sick?
We're all sick. Thank you. This is really good. Thank you. Thank
Very
you.
good.
Thank you. Oh wow, this is great.
Yeah.